Hello, good morning, good afternoon, depending where you're based. My name is Claudia, and I'm with the Marcus Evans Group. Thank you all for joining today's webinar on an impact study of how air purification technology transforms patient outcomes and healthcare economics, brought to you in partnership with LifeAire system. Before I begin, I just want to walk you through a few housekeeping items, starting from your left to your right. I'm going to start highlighting the different widgets. We can have access to the media player, which is where everything is going to be displayed. You will see here the speaker's webcam, but you also will see a video that we later on will be pushing through. You also have access to the slide deck, which should be showing right next to the media player for you. And the slide decks are currently on PDF format located on the resource list. Q&A widgets currently being highlighted. We do want to take as many questions as possible. We have a great panelist today. So please, any question you have during the presentation, submit it through that widget so we can then take those questions right at the end of the event. The help widget also highlighting there is for you to refer in case that you're having any technical issues. But alternative is something that you can't solve it yourself and you would like to ask me, do go ahead and hit the Q&A widget and you'll be able to communicate with me through that. Resource list. The resource list essentially is for you to download any resources, any documents, any white paper you may find useful. I believe that we have a link to LifeAire Systems website. We have the slide deck, and we also have a case study. So go ahead, download the resources so you can have as much information about the topic that we will be covering today. Speakers also are available to you. I have connected or highlighted the LinkedIn profile, so you can go ahead, connect with them via LinkedIn. You also have their email address, so feel free to read a little bit more about their bios, their experiences, and go ahead and connect with them. And finally, but most importantly, we also have a survey. The survey is for us to get more information about you to also modify our content. So I do please would like you to, all of you, to be answering that survey. I'm going to throw in the center of your screen. Once you finalize the survey, please go ahead, minimize, and then you'll be able to continue seeing the event. With that said, I don't want to really continue any delays on these kind of boring things. I want to hand it over to Shok, who is going to be moderating the session, and I'll see you right at the end. Thank you.
Perfect. Well, thank you so much, Claudia, for helping us to kick this off. We're very excited and thankful that everyone could join us today. I'll give a brief overview of who we are and then kind of introduce our panelists so that you know what to expect over the course of the next hour or so. At LifeAire Systems, we are a science technology company. We are supported by more than 20 years of real-world clinical data, and using that knowledge, we take an evidence-based approach to absolutely everything that we do in this critical space of air purification and studying airborne metrics and how to improve them. So today we're going to be focusing exclusively on the health and economic benefits that a LifeAire Systems advanced purification strategy in the healthcare setting. Specifically, we're going to be discussing a 12-month clinical study comparing a LifeAire Systems strategy versus HEPA filtration alone, and again, focused on what those health and those economic benefits were. So this study was actually independently peer-reviewed, and it was published in a major clinical journal, which was the Journal of Surgery, this past September 2020. So our first panelist today that's going to be kicking us off is Dr. Kathryn C. Worrilow. Dr. Worrilow is the founder and CEO of LifeAire Systems. She is a reproductive physiologist by background, and Dr. Worrilow's quest to improve live birth rates ultimately led to the birth of LifeAire Systems. Next, we're going to have Dr. Stewieke, or as he always asked me to call him, Stan, but that's not going to happen today. So Dr. Stewieke is the principal investigator of the 12-month clinical study that I described previously. So he will be walking through and detailing some of the specifics and the takeaways from the study. Dr. Stewieke is a practicing surgeon at St. Luke's University Health Network, and he is also the chair at the Department of Research and Innovation for St. Luke's. And then bringing us home is Mr. Lee Levikoff. So Lee is the Network Vice President of Planning and Construction Management at St. Luke's University Health Network. St. Luke's is a very quickly growing hospital network with hospitals springing up left and right, almost like dandelions. And Lee is in charge of all of that. Not a single nail goes into a wall that Lee doesn't know about. So he's going to be discussing the how, the implementation of how LifeAire gets adapted into a hospital, whether it's a new hospital or it's a retrofit into an existing facility. So without any further ado, I would like to hand it over to Dr. Worrilow, and she's going to kick us off. So Dr. Worrilow, after you.
Thank you, Chuck. And I join my colleagues in both thanking you for your time today, but also for the opportunity to share with you for the first time the results from a large IRB-approved clinical study involving, as Chuck said, over 2,000 adult medical surgical patients over a 12-month period. In the evaluation of the impact of a novel and transformational air purification technology on environmental, clinical, and economic metrics, the results of which offer a paradigm shift, if you will, in how we view the environment serving our clinical spaces in healthcare. Our objectives today, we'd like to share with you a brief overview of the technology, including its unique genesis, an overview of the clinical study design, the environmental, clinical, and economic data specific to the HEPA-protected control floor versus the clinical space protected by the novel air purification technology. And although the study was completed prior to our pandemic, the consequential impact of the technology on SARS-CoV-2 and its variants. And finally, the engineering reality, how to implement the technology, how to bring this to reality in any clinical setting. Our genesis began well over 2 decades ago in the determination to define and provide the ideal environment in which to support the growth of the living cell outside of the body, in particular, the human embryo as cultured during in vitro fertilization, or IVF. Now, because our technology was designed to protect the human embryo, the bar, if you will, was set exceptionally high. And because of that, the technology now offers a paradigm shift in air purification. Our design criteria from our learnings over a 20-year period included, number one, to drive the presence of viable particulates, your bacteria, viruses, and fungi, and your chemical pathogens, or your volatile organic compounds, or VOCs, to drive these to zero. And to do so using mathematical and genomic modeling specific to each bacteria, virus, and fungi. In other words, the complete kill of any bacteria, virus, or fungi is based upon its own unique genomic or amino acid sequence. Now, again, because our goal was to protect the living cell, or the human embryo, we set the bar very high, and we chose the anthrax spore as our target spore to kill. Fortunately, not because we were concerned about anthrax, but because anthrax is the most difficult biological to kill. We had this section of the technology tested by the National Homeland Security Research Center in its effectiveness. As proven with its ability to kill the anthrax spore, that provides a 9-log reduction, 6-log being sterility, in the reduction of the airborne infectious bacteria, viruses, and fungi with which we were concerned. Another part of the design criteria, very important to us, was that all of this was delivered on a single pass of air through the system. So as you see, the system replaces several feet of ductwork. It's an inline in-duct system. So whatever viable particulates or VOCs enter the system, none will exit. We didn't want the air to go through the system 5, 10, 20, 30 times. We wanted all entering air to exit non-infectious or not present. We wanted the technology to deliver these metrics without producing byproducts, ozone, or intermediate molecules, and it's been tested to do so. And we didn't want to use catalyst. Catalysts degrade over time. So if you have a technology in air purification that's using a catalyst, as the catalyst degrades, so does the effectiveness of that technology. And finally, and very important to us, we are a data-driven company, as Chuck mentioned. So we wanted this technology to be completely evidence-based, backed by solid and robust clinical studies proving its efficacy, as well as third-party independent testing. Now, once the design and delivery criteria were established, we sought to purchase something commercially to deliver these. And much to our surprise, there was nothing that we could purchase to protect our cells and patients in our clinical practice. And it was really the absence of a solution that led to the design of the LifeAire system. Our flagship system is a 5-stage system. 3 of the 5 stages involve a proprietary remediation of VOCs. Again, there are 90,000 VOCs, so there's no one magic solution to remediate all. So 3 of the 5 stages remediate VOCs to below detection. There's a central section that will completely penetrate the cell wall or plasma membrane of the bacteria, virus, or fungi, and destroy the associated RNA and DNA so that they're completely rendered non-infectious. And then the 5th stage is finally a capture filter, whether it be a HEPA or an ALPA. It's really the first 4 stages that are delivering the very unique metrics that we're going to discuss today. And typically, if the end user has a final HEPA or final ALPA in their space, we'll simply remove this. There's no need to double the pressure drop. We chose to stay away from the capture approach to air purification because we personally suffered the cellular and clinical failures associated with it. For example, I personally swabbed the ALPA filters, which is 1 step above HEPA. I personally swabbed the ALPA filters that were bathed in UVC light 24/7 above the clinical space we were trying to protect. And much to my surprise, we had quite a few bacillus spores, which are a soil origin, growing on top of our ALPA filters right above the clinical space we were trying to protect. So we chose to stay away from a capture model within our design for several reasons. Obviously, your HEPA, your ALPA are going to capture the organics based upon the size. So a lot of your smaller viruses may not be captured at 100%, and all of your VOCs are going to go through that filter matrix. In addition, the organics that are captured continue to grow. They continue to proliferate. They need 2 things to grow: food and water. Food are often the other organics. Water is simply the humidity in the air. So again, you have infectious organics that are captured by size and continue to grow above the space that you're trying to protect. So again, this is why we went towards complete destruction of the RNA and DNA associated with the infectious pathogens. And again, because of the proven kill for the anthrax spore, the technology delivers a 9-log kill of the airborne infectious bacteria with which we are concerned: MRSA, C. diff, Pseudomonas, Legionella, etc. On the viral side, again, because of its proven kill against the anthrax spore, we provide a comprehensive kill of your more common and infectious airborne viruses, and this is just a short list. We've always included the coronavirus. It is, as you can see, one of the more smaller viruses, just over 100 nanometers in size. And again, the HEPA filter is not able to 100% capture those of such a small size. Finally, on the capture method, unfortunately, we see this far too often. This is an image downstream of a HEPA filter immediately before the air enters the clinical space. And as you can see, the effervescent green glow on the ductwork, after swabbing this and sending this to micro, this is actually Aspergillus fungal spores. And Aspergillus is actually not that small. It is large enough to be captured by a HEPA, but you can have individual cells of the Aspergillus actually split off, which is what happened here, line the ductwork. And again, this is after the HEPA filter, immediately before entering the clinical space. Aspergillus is one of the airborne fungal spores that is very much associated with patient illness in a number of healthcare settings. The design and delivery of our technology is supported now by 28 patents, and there are others currently under examination. And our installed base includes leading U.S. medical centers. In addition to St. Luke's University Health Network, the Mayo Clinic, Stanford, Northwestern, UConn, University of Iowa, Yale, Duke, Wake Forest, and others. Now, thus far we've discussed, jumped ahead one. Thus far we've discussed the unique genesis of, and we've provided a high-level overview of the system's technology. Moving forward, and specific to the application of the technology in healthcare, it's really uniquely tied to two things: the airborne metrics proven to be delivered, and the robust criteria used in the design of the system. Now, as each of you know, at any one time in the United States, 1 out of every 20 patients can develop infectious complications through just being exposure of the hospital setting, costing our hospitals $35 to $88 billion annually. Now, there are two key facts as published by the CDC, very important to the foundation as we walk you through the study that was just published. The first, of the pathogens that cause secondary infections or subclinical illness, 69 to 80% are airborne. 69 to 80% of these pathogens causing these common illnesses and infections are airborne. Number two, greater than 90% of all of your infectious surface fomites or pathogens originate from the air. So we're constantly focusing on the surface, which should not change. But again, it's a very dynamic process because after sterilizing the surface, the fomites can be redeposited simply from the air. Conventional HEPA filtration, as we've discussed, does not provide adequate remediation. And infection control protocols, although everyone is doing a phenomenal job with this, they're not completely eliminating the problem. So our study, which is where we'll present the results from this published study, involved over 8,000 adult medical surgical patients. The duration was 12 months, and it involved two zones. Identical physical footprints, 2 floors of med-surg patients. So we had similar patient etiology, similar staff, and similar SOPs. The study was double-blinded to the staff and patients, and as far as the footprint, each of the floors were supplied by their own individual air handler and protected by HEPA filtration. The upper floor was separated into 2 zones. Zone A, which was completely protected by the LifeAire technology. All supply air went through the LifeAire technology, and all return air went through the LifeAire system. In Zone B, it was HEPA protected, but it enjoyed the benefits from the return air coming from Zone A. Zone C was a complete control, so complete HEPA protected air, as in your typical clinical setting. The study was IRB approved and was analyzed by a number of metrics and variables, including your case mix index, or the severity of patient illness, demographics, and by surgical procedures. Our primary endpoints were the environmental endpoints. This data has now been published, and we're happy to share it. Secondary endpoints were the clinical and economic metrics, which Dr. Stewieke will present. All data was provided by the hospital and analyzed by 2 independent third-party epidemiologists. We now, as of the date of this presentation, we now have the completion of a second large clinical study designed in very much a similar way, but a completely different clinical setting, the results of which mirror the findings in this current study. And we'd be happy to share those results with anyone after the presentation. Prior to the protection of any particular clinical area, we typically have discussions with the clinical team or the healthcare staff as to their clinical concerns. Are they as concerned with volatile organic compounds or the chemical pathogens as they may be with viable particulates? And we've learned that each clinical area has unique concerns based upon the patients that they see, based upon the etiology of the patients that they see. So what's important to understand is that the design and delivery of the technology solution is purposed. It's very purposed to address their specific concerns. Relative to the med-surg area, this is just a short list, but these were, they were more concerned about the viable particulates, your airborne bacteria, viruses, and fungi. And this is a short list of some of the more common airborne pathogens typically responsible for illness in a med-surg unit. And again, our goal was to completely remove these from Zone A. So the selected solution for the med-surg floor was installed. It was energized and commissioned, and the study went live January 1, 2018. For every month of a 12-month period, 3 occupied patient rooms in each of the 3 zones were aggressively assessed for all airborne bacterial fungal loading as well as surface. We used what's called an Anderson impaction sampling device, which pulls air over a blood agar plate. These blood agar plates are then shipped to a third-party laboratory where they conducted and then identified not only the concentration, but the species of the bacteria and fungi present. In addition, we sampled surfaces as determined by our clinical provider. They told us which surfaces were the most commonly touched patient and which surfaces were the most commonly touched clinical surfaces. And these were all assessed each month in 3 rooms per zone for each of the 12 months, all done prospectively. If we look at the control zone, again, just HEPA protected, very typical clinical space. Again, they were following all proper SOPs, all proper infection control protocols, but we have what we would consider very typical hospital flora still in existence. If you look at viable fungi by air, Aspergillus and Cladosporium, viable fungi by surface, the same 2 found in the air were identified on the surface. And again, this is 12 monthly testing for 12 months in 3 different patient rooms per zone. If you look at viable bacteria by air and then the viable bacteria by surface, many of those found on the surface originated from the air, and all of these are responsible for patient illness or infection. So this is the control area, HEPA protected. If you move to the area that was HEPA protected but enjoyed the benefits of the return air from the LifeAire system serving Zone A, we do have a significant reduction in the airborne viable fungi as well as the airborne viable bacteria, and a reduction in surface. If you look at Zone A, which was completely protected, supply and return air by the LifeAire system, we have 0 viable fungi by air, 0 viable bacteria by air. And again, 12 monthly testing for 12 months. And because of the reduction of your airborne loading, you have a significant reduction in your viable fungi by surface, as well as your viable bacteria by surface. What was found were 2 forms of staph, one on the IV control plate and the other on the patient remote, probably related to touch. So again, per the CDC, 90% of your infectious surface pathogens originate from the air. what the 12-month study demonstrated in comparing the HEPA-controlled area to the LifeAire protected clinical spaces, those clinical spaces protected by the air purification system demonstrated a 99% reduction of all airborne biologicals, fungal, and viral loading, which resulted in a 97% reduction of your infectious surface pathogens. So in summarizing it, you're removing two very significant and common sources of infectious pathogens, meaning that you're removing two significant vectors of illness or infection, completely removing the airborne pathogens and dramatically reducing the surface pathogens. Now, as a means to transition to our esteemed colleague, Dr. Stewieke, and he's going to share the impact of removing these vectors on clinical, economic, and capacity metrics, I believe, Chuck, we have a question for the audience.
Yes, we do. Okay, everyone, so we're just going to do a quick polling question here. You should see it up in front of you, but just in case. So what impact will the removal and remediation of infectious airborne and surface pathogens have on patient care and economics? So we have A, none, B, reduced illness and infections, C, reduced length of stay, D, improved discharge outcomes, E, improved cost savings, F, which would be B and C only, or of course G, which is B through F, would all be correct. So if you can go ahead and take a few seconds to answer that, and then we'll have the results. And then after that, we're going to have Dr. Stewieke continue on with the presentation. Looks like we still have a little bit of results coming in. Okay, so we're going to wrap it there. I'm assuming they're all in. So the correct answer is G. B through F are all correct. And as we're going into the results of the 12-month study, Dr. Stewieke is going to shed some light on why that is the case. So after you, Dr. Stewieke.
Greetings. Thank you for the introduction and a wonderful introductory portion of the presentation, Dr. Warlow. It is a great privilege and an honor to be here with this distinguished group today, and I'm very grateful for this opportunity. We're really kind of transforming and changing healthcare. Let me start with a brief experience-based introduction that will create a foundation for our subsequent discussion of the clinical study of the LifeAire system conducted at our institution and, as mentioned previously, published in the journal Surgery. As a physician and a surgeon, I spend most of my days in a hospital setting, and I'm sure that those of you who share and understand my clinical experience will also understand the importance of environmental purity to one's well-being. In the current realm of hospitals, clinics, and nursing homes, air purity continues to represent an unrealized opportunity. It is not uncommon for patients, nurses, and doctors to be literally taken aback by the odors that are commonly present within patient care areas. We must emphasize that these unpleasant experiences constitute a preventable end result of insufficient focus on air quality. Moreover, inherent to the status quo is the fact that our ability to detect specific scents with our olfactory senses also translates to the presence of undesirable airborne impurities, as outlined in the initial part of this presentation, including viruses, bacteria, fungi, and other harmful volatile chemicals. I cannot imagine that these factors or impurities do not, in some way, affect the well-being of those who work or are being treated across our healthcare facilities. Next, please. In fact, the presence of the so-called subclinical infections within the healthcare setting is reasonably well established and documented. What I mean by subclinical infection, as was mentioned earlier, is the subtle yet palpable effect that can be summarized in one phrase. And that's when someone says to you, I just don't feel my best today. I don't feel good. Something is wrong. Whether it is manifesting as sinus congestion, a headache, or lack of energy, environmental and air purity is increasingly recognized to play a contributing role. By proxy, one can translate this general lack of well-being into greater healthcare resource utilization across the board. When you take an entire hospital with hundreds of beds, the expected outcome of inadequate air purity will likely manifest as a subtle but pervasive decline in clinical outcomes, as well as system-wide performance. And this is exactly what our recently published study suggests. In brief, patients who resided in clinical units with LifeAire filtration had significantly shorter lengths of stay, tended to have fewer hospital-acquired infections and readmissions, and had better discharge outcomes, meaning that they went directly to home more often, when compared to patients who resided in HEPA-only serviced areas. Our observed near 40% reduction in length of stay translates into increased heads and beds, greater overall capacity, and better throughput. And what does that mean to the hospital? Economic benefits is the bottom line, approximately $2.3 million in savings over 12 months based on length of stay data alone. What other benefits can this bring, however? Well, if we're talking about increasing the overall efficiency of hospital operations, we're also talking about shorter emergency department stays, shorter wait times, and greater patient satisfaction. The enhanced environmental purity may also translate into greater employee satisfaction. Anecdotally, nurses who worked on LifeAire service units readily noted that the air just felt better compared to what they are ordinarily used to. Next slide, please. Let us look at some of the concrete knowledge that we have about LifeAire system's ability to effectively remediate specific harmful microorganisms. As you can see, this list is extensive and includes a broad range of different types of pathogens, from mycobacteria to SARS-CoV-2, or the virus responsible for the current COVID-19 pandemic. Looking beyond the pandemic, there are also potential benefits to enhanced air remediation when it comes to multi-drug resistant pathogens, such as some of the more challenging gram-negative species often present in, but not limited to, critical care areas and units. We're talking about Acinetobacter, Pseudomonas, and many other extremely harmful organisms. All too often, multi-drug resistant outbreaks within our facilities originate from environmental factors, and although not the sole factor responsible, transmission by air clearly plays a role here. These considerations may also be important in the context of operating rooms, emergency departments, as well as various procedural locations, such as endoscopy suites. Next slide, please. What is well established is that the susceptibility of pathogens to germicidal kill is determined by specific factors within genomic sequences. This was outlined earlier in the presentation. This can and should be exploited to help fight dangerous infections. Because of this ability to target microbial vulnerabilities, the induct LifeAire system is capable of delivering a proven 145 log kill of SARS-CoV-2. This prompted LifeAire's involvement in the White House COVID-19 task force, as well as the ongoing engagement with infection control leaders from around the globe. Next slide, please. At St. Luke's University Health Network, my home base, the LifeAire system was important in our comprehensive institutional approach to COVID-19. In fact, one of our new hospitals currently under construction will feature natively installed LifeAire system, primarily due to its benefits realized at our initial clinical study site in Allentown. We expect to fully capitalize on the overall benefits to the patients, as well as the improved healthcare system performance from enhanced air and environmental purity across numerous clinical areas within our $2 billion network. From operating rooms to neonatal ICUs to emergency departments to skilled nursing facilities. In addition to recently publishing and presenting our peer-reviewed study, we are also conducting new studies across different clinical settings. Of importance, we are finding similar benefits and similar effect sizes associated with independent LifeAire system implementations. Next slide, please. At this time, I would like to introduce Mr. Levikoff, who is a key member of our network leadership team responsible for the implementation and operation of the LifeAire system at St. Luke's University Health Network. He will discuss various economic, administrative, and logistical considerations involved in successfully deploying the system across our facilities. Thank you so much for your attention.
Thank you very much, Dr. Stewieke. And previously, obviously, Dr. Worrilow, thank you for putting this together. I think I'll start out sort of with a story. I'm a construction guy, so I'm going to sort of speak in more plain language. In my mind, I think it's the only way to try to understand this, because this is not a complicated system to put in, install, use, take care of. It may be complicated in the beginning because in order to be as effective as it is, it needs to be. And the key word for us when we were looking at this was the difference between kill, get rid of it, and capture. So I want everybody to understand, if you could, that I'm very similar to everybody else. I'm looking for an advantage over our competition. What happens with us is, if we can maximize our performance and our outcomes, obviously we'll do better than everybody around us. And that being said, we've established a innovation committee here, in which I am part of. And we were lucky enough to hear about LifeAire, and it piqued my interest only because everyone else that we hear from, every email I'm sure everybody in this conference has seen or heard, all claim to do what this system does. And we've done enough due diligence, I'm sure you've heard it enough already from the previous presenters, that nobody else does this. So that's what piqued my interest. I met with Dr. Worrilow, and the first thing we did, besides meet at a restaurant, even before I ate, and I like to eat, was to give her demands, basically laying out a criteria that was, in my mind, very onerous and became almost, I was hoping for, a lot of stumbling blocks and make it hard on them to prove to us that we should use this system. So the criteria for me was just that we needed to be better with them than without them. And obviously, like every other hospital system, we think we're the best. So it was going to be hard for them to prove how much better we could be. In that, let's say, year of conversation, they literally left no stone unturned. They answered our demands, our questions, our design criteria. And this was 4 or 5 years ago, so it was way before coronavirus, way before anything else, obviously, because we're looking for an advantage. Next slide, please. So the reality engineering, the term for a lot of what you do in construction or in even IT, it's a plug-and-play system, in a sense that if you need something, regardless of size or shape or anything that might be in a clash detection system where it would look like it's in the way, maybe a ceiling is low, maybe you have med gases in the way, with their design, we can plug and play. It is in line of the ductwork. It is not something you're going to have to find room for. It is not something that needs to be remote and then tied into. It's literally in line, so it can plug and play into your existing system. As far as existing system, having gone over that, it's a lot easier to think, and usually that's the harder part. But in new construction, it's even easier, obviously, because if you are building new, you're doing it on a Revit system. You're doing it almost virtually before you even put a shovel in the ground, or if in fact you're doing a brand new, you're gutting something and you're doing a brand new fit out. They work seamlessly with that too. And again, I wasn't sure they would do this, but they not only became part of the team, but they led the team, which then would give us the opportunity to see what was necessary for us to get the biggest bang for the buck out of the system, and everybody else would end up working around it because it was still in design. The flexibility of the system, which has allowed us to do that. basically it's a customized system. Now, yes, they do have, and we've used them a lot, the units that they have perfected, size, shape, but for our existing systems, the plug and play falls right into place because they design it to fit our department or even rooms that we would need and think we need this system in. The specifications requirements, obviously, that's pretty much like everybody else is going to do. You're going to give them the criteria. They're going to work to it. The installation time is something I'd like to hit too, because I'm sure there are people on the line that are thinking, okay, where does this go? How does it stay up in the air? What do we do with it? The installation time for a lot of these units, including the ones you'll see later in the slide that look big but go up small, they're typically 4 to 6 hours. So the best part about that for those in my position is our exposure to a bunch of people asking us what we're doing, or a bunch of people asking us, hey, how much am I going to be impacted by this system going up, is minimal. 4 to 6 hours for some of these retrofits. And as far as putting it up into the spaghetti that you have, it hangs from all thread. It'll go up from the existing steel structure. And I've never had a system that literally is light enough that I don't need to add any additional structural support within that interstitial space. The pressure drop that you always will worry about is negligible. It's almost zero. I think it's 0.01. And as you know, with working with HEPA or anything else that's a capture system, it progressively gets worse. So although you put it up and it feels like you're putting up a Cadillac, by the time you change it, it's a Volkswagen. This system doesn't do that. You have the best from start to finish. It does not denigrate. As far as a turnkey solution, LifeAire offered me this, and we took advantage of it in a sense that they came in, they will take care of your ceilings and your walls, your floors, whatever damage that might be done. When I say damage, it could be damage that we did because they're not damaging it. I might put them in an area where I was thinking of correcting something, whether it be in a ceiling or a lighting fixture. They'll put this thing back as if it was brand new. So they'll give you that turnkey situation where you don't have to use any of your own facility support or any construction companies. It's just like an equipment, like an MRI. You have that choice. You can use them from start to finish, soup to nuts, from conception to implementation. They're there for us in a lot of respects. I use them mostly in existing conditions with ICRA walls and training for that and moving med gases. They can do pretty much all of that. The next slide, if I could. Right now, you're going to start to see one of the retros that we did in Revit. I'm sure everybody's understanding that, and all the clashes that would hit this, like a sprinkler system, like your med gases, like your existing ductwork, like the trays for your IT. So we'll work through all of that, as you can see right now, and be able to place the life system exactly where it's most useful and fits nicely with the least amount of work for us to work around. They can do this also, which is terrific, all within that packaged turnkey system. That's a pretty good illustration of what we have in the ceiling now. You see everything else that's in the way at the time. It's now been rerouted, and everything's pretty much perfect. Next slide, please. So the computation. This is basically a list of some of the considerations that LifeAire goes through. And of course, I've discussed the spatial dimensions, all the code requirements, which the best part about it, the positive pressure, negative, the pressure drop, they don't even, it's the best part about it. We don't have to worry about it. With these considerations, before we go into fabrication, we know that even when we test it, it's going to meet the specs. It's going to meet what we expected because it's done in a clean environment when they build them. And again, before they build them, all this is already discussed. Next slide, please. The unit that you saw in the beginning, and you will see in the next slide, is 6'3" by 4 foot in width and 2'7" in height. These are the units, because they're so low profile and 2'7", most of the time you have 5 foot, 6 foot above your ceilings, give you the best opportunity to do the retrofit to an existing building, and doesn't make it difficult to work around. The electrical requirements is something that you've already got in the hospital. You're not bringing something from back at your transformers 700 feet and wondering how you're getting it there. You will have power available. Again, it's 120/208. It's a 20 amp dedicated circuit. So in most cases, again, it plays into the plug and play model. And again, the weight, which we've discussed, 500 pounds. Again, you're hanging it from all thread like you do anything else that's heavy in a system. And ordered to structural steel that you do not have to augment. Pressure drop we already talked about. Another good thing that was a selling point for us and made a really simple decision to use LifeAire was that it worked with the building. The building, obviously, if it does go out of power, when it returns back on, this system doesn't need a switch for us to find. It doesn't mean that your facilities directors are running around the hospital looking at a map. Hey, this is where we hung this unit, turn it on. This returns on as soon as the power comes back on. And you'll know that very well because they designed this for connectivity to your existing management systems. So literally you're monitoring this system like you are any other system within the hospital. Ties right into your control system. I believe the next slide, please. The next slide, obviously, the units that we matched and what you saw on the first slide where we were all standing in next to it, that's the existing unit. That's one of the existing units, which everybody needs to know. They make a ton of them and customized. That's one of the units we did put on in the existing area above ceiling. The other one goes on the building, and what we're doing now, obviously, is building a new hospital and incorporating this into it so we, thank God, have a perfect opportunity to build around it as opposed to having something built first and fitting it. And that is what we're taking advantage of. A vast amount of square foot within this hospital will be LifeAire covered. So next slide, and I just want to sign off by saying if anybody needs to call me, you'll have all that information. Text me, email me, and we'll have that kind of conversation without all the technical stuff. But if you really want to know how this was, I don't want to make it into something that's so easy you don't need me. Give me a call. It is that easy, and you won't need us anymore to try to explain it to you after the first time you try it. Thank you.
Thank you, Lee. So as a summary to all that's been shared, each of us on this panel, as each of you, are driven by improved patient care. And to both Lee and Dr. Stawicki's point, a point of unique differentiation. So we have an opportunity to make an impact, to identify critical clinical areas, and to comprehensively remove or remediate all infectious airborne bacteria, viruses, and fungi. And by doing so, dramatically reduce your infectious surface loading to drive decreased infections, to drive decreased length of stay and improve discharge outcomes, to drive increased patient care and healthcare economics, and increase payer, provider, and patient differentiation. So I join my colleagues in thanking you for your time and the opportunity for further discussions. And please know that we're happy to share any of our publications or address additional clarifying questions at any time. So we thank you.
Okay, I see some questions coming in here under the Q&A. So I am going to take a look at these and then read them off and ask one of the panelists to take care of it, or something that I might be able to answer as well. So let's take a look here. So Dr. Warlow, just to give you a heads up, I think I'm going to ask you to handle this one, which is, to what degree can air purification adaptations to current systems decrease COVID-19 outbreaks in healthcare centers?
So that was, as we shared, that this particular study was finished prior to the pandemic, but during the first wave of the pandemic, St. Luke's chose to add a second system so that they would have 32 patient rooms protected from the airborne COVID-19 virus. And as Lee shared, the installation was fairly nominal. And the system itself has a 0.1 pressure drop. So they really didn't have to adjust anything on the existing air handler or any of the upstream specs. It was a fairly seamless installation. And they did that so that they would have an entire floor protected from airborne COVID-19. And in addition, just as to respond and as a way to try to help during this pandemic, we've actually developed a number of other products based upon the proven and patented flagship system. We've developed other products that can be fit into, really to meet almost any HVAC constraints. I think, as Lee said, it's typically spaghetti above the ceiling. So we've developed smaller products that will deliver the same single pass kill, but in more torturous ductwork, if you will, so that we can help during this pandemic. So whether it's the flagship system that we've presented today or a version of that, using the proven technology, there are a number of ways to dramatically protect your staff and patients from COVID-19. But we always share with our end users and our colleagues, we will get through this. And what we want people to focus on, yes, the focus right now is COVID-19, but there are other more common and seasonal viruses that may never go away. And so we also want to make sure that whatever steps you take, you're delivering the kill not only for COVID-19, but for your influenza, your TB, your aspergillus, et cetera, some of the more common and long-lasting viruses and bacteria.
Okay, thank you for covering that. We're getting a few questions that are all kind of coming and falling under the maintenance category. So I'll just go ahead and handle that one. As far as the maintenance goes, what we recommend in order to maintain the kill efficacy as well as the VOCs to below detection, depending on which model of LifeAire that someone would be going with, is the swapping out of all of our components on the inside, which would be done every 12 months. Now, as part of a LifeAire install, depending on the model that you go with, some of the proprietary elements would be shipped back and analyzed to determine their maintenance schedule. But typically every 12 months is the recommendation to have those changed out. Now, in some cases, and I can see here from the questions they're asking, whose responsibility does that fall under? It's really at whatever the customer would want. So it's up to you. We have certainly sent people to change out components and help with that. That's something that we can do and assist with. And at the same time, it's not that overly complicated. So it's something that your building management system, your maintenance team would be able to handle. Under the umbrella of maintenance, it is BACnet. Our systems are BACnet enabled, so you would be able to tie into the building management system, as Lee mentioned earlier. By doing that, you can follow things such as a system function to maintain that everything is on. If you don't want to tie into the building management system, we do have touch screens that come with this, so someone could physically monitor the screens for activity and to make sure that everything is in working order. Usually, accounts that we work with prefer to use the tie-in to the building management system. So that's the long and short of the maintenance. And taking a look at here, we're asked a little bit about cost. There's a few questions about cost, and I can handle that one as well. As Dr. Worrilow mentioned earlier, form follows function. Really what that means is we would work with each individual account, institution, person, what have you, to determine what clinical areas your desire is to protect. So if it was one building, a smaller medical office building, and you wanted to protect the whole thing, certainly we could size that out and do that. If we're talking about a hospital, we would probably work with you to take a look at what your highest risk areas are where you could benefit the most from the data that's in the study that Dr. Stewieke covered today, meaning your critical care units. So we're talking med-surg, PACU, ORs, ERs, NICU, ICU, things like that. Those are typically the targets if you're going to start somewhere where you're going to get the most return on your investment. So we would work with you again on that. In terms of the good news is with healthcare, part of the criteria of how much coverage you get with one of our units, part of the formula is how many air changes per hour that you're doing. So in the, where the birth of LifeAire came in IVF, IVF labs run higher air changes per hour, 15, 20, 25. So a LifeAire system, say a 4,000 CFM system, would not get as much square footage coverage. Whereas in a hospital, the good news for anyone on this webinar today, in hospitals, air changes per hour are usually run around 4. That's pretty much standard ASHRAE code. Waiting room, sometimes 2 air changes per hour, OR, sometimes 6 or 8, but it's kind of in that range. And so a 4,000 CFM would stretch much, much, much further in terms of your overall coverage. And then getting back to ROI, in the St. Luke's study, when Dr. Stewieke mentioned the $2.3 million of economic benefit that was due to the reduced length of stay, which translated to $2.3 million on those 16 beds, what that means is it's 24 times your initial investment in terms of your ROI, and that's just in the first 12 months. Now, those are the payer mixes for St. Luke's here in Pennsylvania. Even if your payer mixes were different, I mean, you could even be conservative and cut that number in half if you wanted to. The ROI is definitely there. And again, that's just in 12 months. And as far as specifics on costs, we're more than happy to work with you. Just reach out to us and we can talk about strategy for what areas that you're considering protecting. And then we can kind of get into the specifics from there. Let's see what else here. Okay, we talked about this one a little bit, but I'll kind of ask Katie if you could handle it. It's another HEPA-related question, and I know you covered it, but it's coming up here about since HEPA is what everybody's used to hearing, why is LifeAire different in terms of benefits over HEPA? And probably you could just speak to the difference, right, of filtration versus purification. But there's actually a couple HEPA questions in here, so I don't want to ignore those.
Absolutely. Again, we chose to stay away from the HEPA or ALPA capture model, if you will, because we personally in our clinical practice suffered the consequences. Again, they're going to, the capture model, HEPAs and ALPAs are going to capture based upon size. And so you have the viable organics literally growing above the space you're trying to protect. And then you have significant air velocities crossing that filter, allowing the possibility that the organics could enter the space, which we did have happen. In addition, all of your VOCs are going to go right through, whether it be HEPA or ALPA, and a lot of your smaller viruses will not be 100% captured. And I mean, really, our goal was penetration of the cell wall of the bacteria, viruses, and fungi, and complete destruction of the associated RNA and DNA, so that if the shells of the bacteria, if you will, were to enter the clinical space, we knew they were completely non-infectious. That was very important to us.
Good. We have another one here from Jeff. Required maximum air velocity is not a limiting factor when installing a retrofit. Requiring increases in ductwork size, question mark. So at the end, Jeff's asking, what is the maximum air velocity? And I can certainly handle that one just based on. So essentially, if we're talking about maximum air velocity, we have 4 models that we kind of have as our standard models. But again, we work with the needs that you have, and we can certainly customize, as we have done several times. So if we just look at we have say a 4,000 CFM, that would be 500 feet per minute. And then we have a 1,000 and 2,000 CFM, and those would be 250 feet per minute. Again, LifeAire has been installed in over 50 locations in North America, as well as some out of the country, including about half our retrofit. We've never had an issue not finding a way to make that happen, whether it's changing the size of ductwork or customizing our unit for that velocity. But on those standard units, Jeff, for 1,000 and 2,000, it's 250. 4,000, it's 500, to answer your question there.
And Chuck, if I could just add to that, one thing that's very important to us, just to add to Jeff's question, we in looking at any space, it's very important to us to look at all of the HVAC metrics. You know, the existing air handler, the existing ductwork, obviously the cubic volume of air in the space that's desired to be protected. And we really use our own algorithms to model the ideal solution for that space to take into all of their existing HVAC constraints. And that includes existing air velocity. So that's very important to us. And it really has to be done to guarantee the delivery of the metrics that we are sharing today.
That's it on the Q&A. Claudia?
Yeah, thank you so much. I just want to say thank you to all of you. I think that there has been great insight. We know that there are some questions that we didn't get around, but the hour just hit. So I just want to be respectful with everyone's time today. So once again, to you all, thank you so much for joining today's event. For those that haven't managed to answer that survey, or perhaps join us a little bit later, I would like you to go ahead and answer that very briefly survey, 3 quick questions, hit at the answer, and then we'll get back to you. Once again, on behalf of LifeAire System, Marcus Evans, and the rest of the panel, I would like to thank you all, and I do hope that you have a great day. Thank you.
Thank you.
Thank you. Please
Thanks.
stay safe. Stay well.
Same.
Thank you.
Thank you, everyone.